Welcome back to the Nutrimedical Report, and we have some remarkable information for you. If you have cancer, if you have a relative with cancer, you want to hear the latest news from Dr. Stanislaw Brzezinski, probably the most advanced cancer research scientist on the planet now for a number of years. He's been a teacher in our academies of anti-aging medicine, advancement in medicine, and environmental medicine for many years. The whole theory is that cancer is a gene-based disorder. He discovered many years ago that antineoplastins are molecules present in normal people that don't develop in cancer patients. And when you replace them with given antineoplastins, you affect up to somewhere up to 100 to 150 genes that actually prevent cancer from happening. There are also tests that can be done with a biopsy or flow cytometry to look at genes and laboratories that they utilize, such as in Phoenix and elsewhere, that can tell you off-label use of now, I think, 75 to 100 plus drugs that actually are off-label use to actually switch those genes back to the normal position. The combination is very, very effective at being able to reverse many very advanced cancers. In fact, success on some cancers where the 5-year fatality rate is infratentorial tumors and breast cell tumors of children is remarkably high. When you talk about, say, 42% survival, when the 5-year survival rate for those type of tumors on conventional treatments is less than, as basic doesn't exist. This gives people hope when there is a position of hopelessness. So, Dr. Stanislaw Brzezinski, tell us the latest news of what's happening, because it's great to have you periodically back on and give us an update of what's happening at your research facility and your outpatient clinic in Houston, Texas. Dr. Brzezinski, we have you on the air.
Hi, it's a pleasure to talk to you.
So, what's the latest news?
Quite a few events recently. About 3 weeks ago, FDA gave us a permission to proceed with phase 3 clinical trial. Wow. As you know, for approximately 2 years, we are on partial hold, which means that we could not admit new patients to clinical trials, but this has been removed because FDA admitted that they received sufficient information from us to proceed further. So it looks like we are back to the situation which we were before placement of what is called partial hold. So currently we have phase 2 clinical trial which is permitted by the FDA, and we are now putting together logistics to move forward on this one. And then we have another study protocol in the FDA, which is undergoing review now. So it looks like we are moving ahead, and at this moment we are enjoying cooperation with the FDA.
Well, that's really good news. Now, the phase 3 trial, what are the key points in this phase 3 trial, and what kind of cancers are going to be open for the trial admission for this type of therapy?
This is for perhaps one of the worst type of malignancies which exist, which is for malignant brain tumor in children. It's called diffuse intrinsic pontine glioma. The difficulty originates from the fact that this tumor is located in a strategic place in the brain, in pons, which connects the brain with the rest of the body.
Right.
And unfortunately, it cannot be removed because then the patient would die. So surgery is out of question. Right. The only possible treatment is radiation therapy, which can extend the patient's life, but unfortunately it's unable to cure it. And it cannot be used in every patient. For instance, it cannot be used in children less than 4 years of age. Unfortunately, this tumor frequently shows up in children as little as 1 month of age. Unfortunately, despite such treatment given, only about 7% of children survive 2 years, and all of them are dead at 5 years. So this is very grim statistics. We completed our phase 2 clinical trials in this type of tumor, and we proved that we can save a good number of these children. Just across the board, our survival at 5 years is approximately 20%. And in this category, some of our patients are surviving even over 25 years, and they live normal life. We realize we can't help everybody because this is not just a single type of the tumor. There are a number of different varieties. And these varieties have different genetic makeup. So we know that we can help some of these patients, but for the rest of the patients, we are still working on successful treatment. So for this type of patient, FDA permitted to proceed with phase 3 clinical trials, which will compare the results of radiation therapy with the results of a treatment with angioplasties in combination with radiation therapy.
Yeah, that's excellent. Now, if someone has an unusual tumor, let's say they've got an adult, say with 20 years of age with a brain tumor, and they have, let's say, they don't want to do conventional therapy. They don't want to do what I call paint by numbers chemo. What they would like to do is not do radiation therapy either, because a lot of people know that they get radiation-induced changes to brain function. We call it chemo brain and radiation brain. What you use, of course, is anti-neoplastins and low dosage of off-label use of drugs, so you don't end up with the really horrible side effects after someone recovers from their tumor or has an extended period of survival. Can you give us an idea of, obviously, of how people go through the process of getting to the clinic, the facilities outside the clinic, the costs for them to do that, and what kinds of tumors are available? Because obviously you don't treat every kind of cancer. You're selective in the kind of patients you know that will benefit from your type of approach.
Certainly. This is incurable brain tumor, and there is more flexibility in the treatment of such tumors because there are no standard of care regimen available except for radiation therapy. Well, to be able to treat patients who did not have prior radiation, we put together the second protocol, which is now under review by the FDA. And in this second protocol, we can accept patients who didn't have prior treatment, and the patients who will not have radiation, they will have just treatment with antineoplastons. So this is something which FDA agreed to review, and we hope that this study also will be permitted by FDA soon. But here we are talking about clinical trials, which certainly have some entrance criteria, and not everybody can be admitted. So the question is, what can be done for the patients who are not in clinical trials? Well, for such patients, there is a possibility of taking advantage of what is called expanded access to investigational medications. We have a list of malignancies for which we can apply to FDA to ask for what is called single patient protocol. It's a lot of paperwork involved, but FDA is willing to review it and give the permission to treat patients outside clinical trials. And then the criteria for admission of such patients are much more relaxed. Also, there is some other possibility of treating a patient. Apparently, any doctor in the United States can apply to FDA through the mechanism which is called single patient investigational drug permission. They need to put together a single patient investigational drug request, and when they apply to FDA, FDA may permit the treatment which has nothing to do with clinical trials. It is designed for the treatment of patients for whom standard treatments do not work. We have already such doctors who successfully applied to FDA and they received the permission. They can treat malignancies which we cannot treat in our clinic because they are not on the list with the FDA. So this is about using of...
so you have a network of doctors, too, that are working...
Of course, there are some other avenues when the patient can be helped. One of the medications from antioblastin group is now approved by the FDA as prescription medication, and this medication, together with some other medications which work on the genes, can be used in private practice. So this really requires evaluation of single patient and to find out if this patient qualifies for such treatment. And here we are talking not only about brain tumors, but about any type of advanced cancer, which is difficult to treat by standard methods.
Right, so lung cancer, breast cancer, liver cancer, etc. Back, and we're talking on the break with Dr. Stanislaw Brzezinski of the Brzezinski Clinic. That's BURZYNSKI Clinic.com in Houston. And, of course, you have affiliate doctors and that will utilize your antineoplastins and gene-based targeted cancer therapy around the world. And the act, in a sense, is an extension. Many people will come from Taiwan or other countries to be evaluated first at the Brzezinski Clinic and then continue in their own country. Is there a situation where someone, let's say, can't travel or it's difficult for them to travel, say from South Africa, where they can contact and get the history evaluated, determine if they can get the country approval for the IV antineoplastins and the off-label use of specific drugs to try to help their cancer? Is that possible? Say if they're in Britain or South Africa?
Absolutely it is. If the patient has difficulty to travel, then the treatment can be organized at home. For this reason, we need to have a very good oncologist who really would understand what we are talking about, and we can guide him how to use the treatment. For some countries, FDA does not require a special request for transfer of the medications, providing that this is an agreement with the foreign government. But for some other countries, it is necessary to ask FDA for the permission. And such permission can be given within a short period of time, or sometimes it takes a long time. We really don't know what is the mechanism which governs. It depends. Such permission can be given, but such mechanism is available. And we use this mechanism for supplying medication to various countries in the world.
So if someone contacts you, let's say they're in Michigan, and they have, let's say, a lung cancer, and it's already metastasized to the liver in their posterior retroperitoneal nodes, and they don't want to go through full dose chemo or radiation therapy, and they prefer to do the Brzezinski approach. What's the procedure for them to contact you, get their medical records down, get their doctor and oncologist on side? What's the procedure for them? Should they be sending the records forward and then getting tests done immediately to get the gene-based research done already, or to fly in and actually then come to the Brzezinski Clinic and then get an evaluation for a period of days or a week or more? How do they go through the whole procedure?
Well, obviously, we are contacted by patients from all over the country and from the other countries, and we don't want them to travel long distance if we are unable to help them. So first, we need to do some screening. For this reason, we usually ask them to send us medical records. The doctor in our clinic will evaluate medical records to find out if the patient is candidate. And we give preference for very advanced cancers for which really there is not much hope in elsewhere. And such patient, if he is able to travel, comes to us, we evaluate him, we start him on the treatment. Usually we run gene testing also to find out which medications are best for him. And after a while, usually this is about 2 to 3 weeks, we send him back home and we work with the local doctor to continue the treatment. So this is really simple. And we have very good cooperation with a number of doctors all over the country. So that's the preferable way, because we can evaluate the patient here, we can find out what's the best for the patient, and the rest can be done together with oncologists in different cities.
Yeah, exactly. Now, what's the if someone has insurance, does insurance cover part of the treatment at your facility, or do they set up some kind of a payment program? How does it work if, let's say, they're not going to a protocol or research study, which of course is going to cover their cancer therapy because it's a research protocol? How does it work in terms of financial side for them to be able to evaluate? Let's say the cancer is now accepted. How do they move forward on that?
Well, the good news is that the basic things, which is testing for the alteration of the genes in the tissue taken from the tumor, this is usually covered by insurance and includes also medical coverage. We don't do it in-house. We simply facilitate transfer of the tissue to the laboratory which is doing this. So this is really, I would say, painless. It doesn't cost the patient, and usually the tissue which is used is the tissue which was removed from the tumor some time ago.
Right.
So this is good news. Then the rest of the insurance coverage depends really on the insurance policy. We have very good experts in our clinic who will review the insurance policy and find out if there is a good chance that the insurance will cover. we are trying to use medications which are approved for a particular type of cancer, and more medications are being approved these days. So usually we can find in our combination at least 1, 2, or maybe 3 medications which are specifically approved for the treatment of this type of cancer. And then the insurance is usually paying. Of course, for the patient who exhausted standard of care approach, we have to look for the medications which are off-label. And regarding off-label medications, this really is a different story. Some insurance will cover this, some others will not. In many cases, we need to provide justification why this treatment is appropriate, and we are using then background from gene testing. In some cases, the medications are provided free by pharmaceutical manufacturers, and the patient is not going to pay anything. But again, let's face it, for some patients this is going to be expensive venture because they may need to obtain medicines from the pharmacy and they may need to pay for it if the insurance doesn't cover. But we are trying to do whatever we can to alleviate the problem.
Exactly, and of course we know that a lot of times you just go and contact your insurance carrier, even if it's off-label, to go through an approval process and approve it even if it's off-label because the doctor thinks it'll be helpful in that condition. So we often find that's not a major barrier if people have reasonable insurance.
Go ahead, please.
Well, the key...
In this area, we enjoy reasonable success. Our doctors can provide justification, and in many cases, the patient is receiving medications within a short period of time. Or they may receive free samples from pharmaceutical manufacturer, which is also very good. And surprisingly, in some cases, this is for the patients who came long distance for the treatment to the clinic, and somehow pharmaceutical manufacturers may provide medications for them without any charges. So this would be the preferable way to do, but certainly this is not available to everybody, and that's something which we are trying to obtain, but it's not always easy.
What about on the effect of the ACA, the Obamacare Affordable Care Act? Has that had any positive or negative effect in terms of access to your clinic and your treatments?
Well, no, what we are trying to assure is a long-term survival of these patients. So that's the golden standard which we would like to employ, which means make sure that the patient will survive much longer than on regular treatment. And we are enjoying good success in this area, especially if you are talking about such incurable malignancies like advanced or recurrent brain tumors. Even such terrible cancers like pancreatic cancer or mesothelioma still seem to have increased survival of patients who are taking this type of treatment. But obviously, it depends on individual patients. Some patients enjoy much better results than the others, and it's highly individual treatment because this is a personalized approach.
Exactly,
to find out whatever is the best for individual patients.
Right. So I think what people should do is they should contact the clinic, find out with their doctors, get their records evaluated, see if they're a candidate, check to see if the doctors can do whatever they can with their insurance rather than making assumptions. It's because it's so advanced, it's going to be expensive and beyond their means. Well, in many cases, lots of things can be done to make it affordable. We have Dr. Stanislaw Brzezinski here from the Brzezinski Clinic. That's BURZYNSKI Clinic.com. Dr. Stanislaw, on the break, you mentioned that you've had 9 articles that have been printed. Many of them are going forward for publication. You're encouraging collaboration rather than, a competitive approach to cancer therapy, which means other clinics, whether it's Mayo or the Sloan Kettering or any other cancer clinics, they should, and I would assume that a number of them are probably starting to move into the idea of gene-based cancer therapy, because cancer, in a sense, is anaerobic tissue that has abnormal genetics, gene switching, and you're the discoverer of the fact that antineoplastons are not present in cancer patients, but they're present in normal people that don't end up with cancer developing. The fact is that cancer is a genetic disorder, not an immunological primary problem. It becomes secondary immunological when the person's immune system doesn't pick up cancer cells, but it's not an immunological disorder, and it's primary nidus. And you're the researcher that discovered that cancer approaches should always be gene-based. I think that this is the only way that cancers can be defeated, is to identify a gene-based switching problem even before. In fact, I think one of the research I talked to years ago, after I'd heard your lectures back in the academies, was the idea that blood or stool tests looking for specific gene switches were going to be the wave of the future. Well, you're there. I mean, so the fact that you're publishing means that you're encouraging other cancer clinics to say, get on side, do this. We'll share you our protocols. Please do what we're doing, or advance it further, or show that you can make further contributions to this whole movement of cancer therapy. That's very, very excellent on your part.
There is no doubt that if you would like to treat cancer successfully, you need to find out what is causing cancer, and you end up with finding out that these are the abnormalities in a number of different genes, which are different in every patient. You identify this, you find out proper medications, and then you have a good chance that you will get good results. So basically, at this time, we hope to publish the strategy how to successfully treat recurrent GBM, glioblastoma, which is deadly tumor. About 40,000 people in the U.S. suffer from this, and the survival in most of them is less than 6 months. So you can turn this around. You can really show the doctors how to really get rid of this horrible prognosis by using a combination of medications which are available as prescription medications. So I am sure that many of the doctors will disregard it, but some of the doctors will try it. They see good results, and then they will have a domino effect. And hopefully such horrible prognosis will not exist anymore in a few years to come.
Are there any augmentative therapies you think might help improve even the efficacy of the gene-based therapies, whether it's hyperbaric oxygen or specific nutraceuticals or anything else that you think is helpful to either prevent cancer or to augment or increase the ability of the cancer therapies? But for example, one of them is total body alkalinization or hyperbaric oxygen or other types of therapies. Has anybody researched to suggest that some of these might be improve efficacy? I mean, obviously...
this will be the next stage of testing what else can improve the results, because this also needs to be studied scientifically. At this time, I think diet will be very important, and certainly a certain type of diet will help to obtain remission faster. We evaluate dietary and metabolic status of every patient, and we are trying to give them instructions what to do to use diets to help the results of the treatment. So this is important, and there are some other teams who are working in this direction. So I'm sure that whatever we provide plus dietary approach will be very important. But the other avenues how to help these patients, I think they need to be tested, and hopefully find out something else which will be also useful.
Right. One of the things that I've contacted, this is regarding heart disease, was looking at gene-based markers like angiogenesis and cell proliferation, which we know are affected in cancer, apoptosis, chemotaxis, and inflammatory markers. And they look at that in heart disease, but I would imagine there's a number of these gene-based markers that would give you a predictive idea, and if they're modified by either diet or nutraceuticals or these drugs, those would be a real positive thing to look at these specific markers and see if we can change the profile for someone who either has cancer or is at risk of cancer because they have certain gene, like the BRCA2 panel, which we know, some movie stars have actually had their bilateral breast mastectomies because they thought they were almost certain to be developing cancer, when really it's not inevitable. It's an interaction between toxins, diet, and lifestyle, whether or not someone's going to get cancer. It's not an inevitability that if you've written your genes, it's going to happen. What advice would you give?
This is quite complex, but it can work quite well.
Yeah. So what kind of diet do you recommend? Because I tend to push kind of like the Mediterranean, healthy fats, low carbohydrate diet that's basically an alkalinizing, low carbo, low sugar load, hypoglycemic type of diet for everyone, whether it's heart disease or cancer, and it seems to help with basically keeping people healthy.
These are general recommendations, but we are trying to really look at this from personalized point of view. We would like to find out what kind of metabolic changes we see in this individual patient, and then try to correct it and change it so then we can support cancer treatment. But certainly there is a background for ketogenic diet, and there's a background obviously for diet which does not provide free sugars because they feed cancer, the diet which does not have a lot of amino acids like glutamine, because glutamine is also the main fuel for brain tumors. So this is quite complex, because people who are coming to us, they're coming from different ethnic groups, and these different ethnic groups have some differences in metabolism, and they need different dietary approach. But
so in other words, if you
have metabolic profile, then we try to give them proper consultation and tell them what kind of diet they should use.
So the doctors at your clinic can actually do a metabolic profile and then say, okay, because of your specific, let's say, amino acid profile, we shouldn't be feeding your tumor with increased glutamine.
Absolutely, but this does not apply to all patients, because in some patients glutamine does not hurt.
Right.
But I would say just across the board, in 75% of brain tumor patients, glutamine will stimulate the development of brain tumors. In the other patients, it could be tryptophan, and also we have to avoid it. But this is highly personalized. We run amino acid analysis, for instance, in blood to find out what we should avoid and what we should emphasize. So that's to give you the example. So this is a complex situation, but with proper management, we are learning better and better how to help the patient. And the results are quite obvious. You repeat MRI, say, in a couple of months, and you see the tumor is greatly reduced or practically gone. So we see this quite frequently, and that's very encouraging.
Now, some of the range of tumors, let's say, and we know that you've done a lot of research on brain tumors. What about lung cancer, liver cancer, let's say related to hepatitis B or C, bowel cancer, genitourinary cancers? Can you give us an idea of the range of other cancers where you've had, phase 1 and 2 trials, or you've had, patient experiences that have been shown remarkable success with specific kinds of cancers like colon cancer or liver cancer, lung cancer?
Well, certainly we see patients who are diagnosed with great variety of malignancies, and we frequently see those who have common cancer like colorectal cancer, breast, lung cancer, etc. But this needs to be approached systematically. Now we are compiling our data and filing what are our results in personalized targeted therapy in these various types of cancer. We already published the results, for instance, in ovarian cancer, which shows very good responses with targeted therapy combinations. We published some reports on triple-negative breast cancer, on some type of pancreatic cancer, and some rare form of cancer. But at this moment, we are trying to find out statistically how are we doing, for instance, in recurrent pancreatic cancer, which is pretty much hopeless. We are talking really about advanced cancer when the cancer spreads to the body. Today I finished some work on advanced mesothelioma, which is...
See, one of the things that's happening is we have a very toxic world. And I belong to both the Academy of Advancement Medicine, Anti-Aging Medicine, and Environmental Medicine. I started work back in the 70s before I went to medical school in 73 as an environmental oceanographer, and then I did biochemistry work in medical school and residency. I was supposed to actually do a PhD research neurology residency at UCLA back in 78, and of course I decided not to proceed with that because they wanted me to do some what I call unethical DARPA projects, the Defense Authorized Research Project, DARPA, which people who have listened to the program understand. What I see happening is that we have a very toxic world. We have toxic food that's been modified in our food industry. We have toxic chemicals entering the troposphere and in our food, air, and water. We have toxic electrotoxins from cell phones and Wi-Fi networks that are affecting people's genetics epigenetically. We have heavy metals that are not only in the atmosphere. We've been reported by our Academy of Environmental Medicine 11 years ago by the U.S. Geological Survey and NASA that much of the heavy metals in our food actually is coming from China and Indonesia and other countries that don't have scrubbers on their smokestacks, and they spew tremendous amounts of heavy metal pollution and other toxic chemicals. All these things are increasing cancer rates. And when I went to medical school, the cancer rates were a tiny fraction of what they are now, 41 years later. And so as a result, when I look at the situation, being able to do preventive things for cancer and picking up cancer earlier, gene-based cancer tests to actually find cancer at early United stage, by the time they often reach your clinic...
Certainly, preventive product will be extremely important, and this will be also based on genomic, or what is defined even better, epigenomic approach. It looks like the first change in the formation of cancer could be what is called epigenomic, which means blocking the activity of the gene which protects against cancer, which is called tumor suppressor gene. And here, the proper diet and the supplements can help a lot, because dietary ingredients contain a lot of chemicals, which are natural chemicals, which can activate the genes which are blocked by various influences from the environment. So this will be very important, but this would require certainly large studies which may involve thousands of patients to find out statistically how this may work. Just to give you an example, for instance, in Southeast Asia, one of the main toxin which is found in the food is aflatoxin, which is produced by certain fungus. And it's very common. It exists in rice, it exists in peanuts, it exists even in beer, or it exists in meat, like duck, when the meat is prepared. And it is estimated that in the years to come, it will cause something like 10 million cases of liver cancer, primary liver cancer, which is uniformly deadly, And this disaster can be prevented. It was found that this toxin is neutralized in the main gene which protects us against cancer, which is called P53 gene, and by using proper dietary management, and here also we can use one of our supplements, which in laboratory animals prevent formation of this type of cancer. So this will be very important, because this is like a ticking bomb. It's very difficult to avoid contamination of the food with this carcinogen, and by using proper nutrients, this can be avoided. But it would require more research and some dietary regimens which can help patients, or some supplements.
Yeah, exactly. We have now, for example, research in Johns Hopkins University on the research developing ellagic acid, which is from the terminal Chibulia, 300 times higher concentration of pomegranate for blocking cancer cell activation, and also research at the same university dealing with sulforaphane glycosinolate from broccoli seed. Those are all very helpful. Also, we find that cancers grow faster when people's vitamin D levels are low. There's a number of different things in the person's diet, including the ratio of pro-inflammatory to anti-inflammatory fatty acids in their fatty acid profile that promotes cancer. So to some extent, cancer is an inflammatory process that also deals with hypoxia, the presence of toxins and stealth pathogens, because we often find cancer seems to be affiliated with certain stealth pathogens present in the body as well. So it's kind of like, if you want to call it a multifactorial epigenetic mess that's occurring. And of course, as the population gets more toxic, the cancer rates are going up quite a bit.
So that's obvious that this is multifactorial approach. But if we take into consideration that there are about 700,000 of active ingredients in dietary stuff in foods or in various supplements, then this is really a wealth of materials which can be used to prevent and modify the disease. But this needs to be studied systematically. It will take time, but in the future, I think it could be very hopeful that such approach will prevent cancer and some other diseases.
Let's return to the original process. If people want to contact the Brzezinski Clinic, what's the phone number to contact? And the website is Brzezinski Clinic, BRZYNSKI Clinic.com. What's the clinic phone number for them to contact, the 800 number?
Well, we have 1-800 number, which is 1-800-714-7181 is 1-800-714-7181. So please feel free to contact us. We have a team of people who can help you and who can give you information and who can find out if we can help you. Obviously, if we can help you, you'll be invited to come. And
I tell people, don't be frightened if you don't, quote, have regular insurance, or you don't, if you think your insurance may not cover things. They'll work with you. The drug companies may work with you. The big biggest part of the cost. A lot of time they'll have humanitarian aid for off-label use of drugs. As I say, many of the drugs that are used for your therapy are large drug companies that often have humanitarian programs. What people should do is they should not close off that door, especially if they're dealing with the danger of cancer. And they don't want to go through radiation or conventional chemotherapy, or they're not a candidate. They should also realize that if the cancer is really extensive, you can't delay. You need to get those records off to the Brzezinski Clinic right away, evaluate if your treatment is available there, and number one, two, see if you can get the cancer tumor test done to see which genes are actually activating the cancer, and start the whole process. And I recommend diet, nutraceuticals. I recommend that people get connected to the clinic right away. And whether they add other augmentative therapies, I think the first thing is that cancer is a gene-based problem, and your clinic is definitely the lead clinic in the world. And you work with doctors everywhere. I mean, you work with doctors whether they're in Japan or Europe or Johannesburg. You'll help doctors anywhere, which is great because you've published all these reports. What's on the radar in terms of new testing or new studies that are coming up, Dr. Brzezinski?
Well, the new studies are coming in various peer-reviewed journals, but the one I am referring to will come in a special edition on gliomas, which are primary malignant brain tumors. We hope that this one will occur in September, and we'll be glad to distribute the reprints to the doctors who are interested, but they probably will get it from the internet without any problem.
Exactly, yeah. Well, I'm really proud of you, Dr. Brzezinski. You're a real physician, a healer, because you're approaching it from a scientific point of view. You've not been afraid to deal with all the negative press and push over the years. You've now got collaboration with the FDA. They've moved to phase 3 trials now for your new studies. This is a very positive thing, and it means that other cancer clinics, if you're listening, doctors around the country, including family doctors, internists, etc., or pediatricians that deal with children's cancers, you need to contact Brzezinski if you think that a person you've diagnosed has a tumor, that rather than giving up or just going through conventional therapy, offer the alternative of getting gene-based therapy, which has much higher success rates and much lower morbidity and mortality rates. Many of the cancers, for example, children's cancers that are infantorial, have a 0.5% survival rate, and you have considerably more than that. It is 100%, but it's a lot better than the current situation with conventional therapy. It's amazing.
Well, thank you very much. It was a pleasure to really explain this to the listeners, and we really hope that we can help people.
I'm really proud of you, and I'm proud of all of the teaching and research you've done. I'm certain that as cancer therapies spread around the world, to remember that it was the Brzezinski Clinic that started all gene-based therapies, and that's what the nature of cancer is, a hypoxic anaerobic cell, switching genes on and off, and you've done the research in antineoplastons and off-label use of drugs. That's what cancer is, and you've shown the way that this is how we're going to defeat cancers, to know individually what the gene switches are for each cancer by itself, rather than customized gene-based therapy rather than paint by numbers. Very, very amazing.
Well, certainly. That's the way of the future, and we'll be glad to help patients, and we'll be glad to work with the doctors who would like to use this approach.
Amazing. Thank you, Dr. Brzezinski. Again, Brzezinski Clinic, the clinic number 800.
Hopefully we'll talk again soon. Thank you.
Absolutely. 714-718-1800, 714-718-181. Don't be frightened by any issues.